Well, good afternoon and welcome, everybody. Let's get started on this next session. So this is the welcome to the Enhancing Clinical Practice and Outcomes stream of the SNOMED October 2023 Expo. And my name's Monica Harry. I've probably met and seen all of you around this last week, but I lead the content and mapping team. And I'll be moderating today's session. Just a reminder that all questions and answers will be dealt with at the end of the session. So if you could just hold on to your questions, that would be great. Thank you. And anyone online can do the Q&A in the Zoom call. And if you're going to ask a question, I'll remind you as well at the time, but use the microphone so that people online will be able to hear you. So I'm now pleased to introduce Filipe Mealha and Sarah from the SMPS, who will be presenting complementarity between SNOMED and LOINC, a clinical pathology use case. Please go ahead.
Thank you. So good afternoon, everyone. Hope you had a nice lunch. So before we get to the good part, let me just set some context for you. So both Sarah and I are from SPMS, which is the Portuguese e-health agency, and we do two things in SPMS. So on one side, we act as a software house. So we developed our own information systems that are used in public institutions. And then on another side, we act as a regulator. So maybe this doesn't happen in many countries in the world, but this is how we are set up in Portugal. And if you look for context, you see we are around 10 million citizens, and we have 54 public hospitals, almost 600 primary care units, and then all of them are running our own ICT systems. So we have seen this shift in information systems where systems are getting more and more specialized, more and more departmental. So we are seeing an end to these big monolithic systems, and we are assisting this change where companies are really getting specialized in the products they are serving. And this has made us revise our interoperability strategy as a whole. So a couple of years from now, our strategy has been, to put it simply, to build platforms. And what I mean by this is that we want to create this place, this digital market, where service providers and service consumers can exert their digital activity, but this should all happen on top of the infrastructure that we control. And if you look at the interoperability framework, this is defined by the European Commission. So on a technical level, we are setting rules that establish how these connections between systems from different providers should happen with our central platform, which is there referred to as PNB, which stands for Portuguese National Broker. And this is just a big message queue system that distributes communications between several providers. So we start with the technical layer, and then we also define specifications on how the information should be exchanged between these providers. But this is not enough to build trust. And so there are two other layers that we tackle, which relate to legal aspects and what are the key things that you need to identify both from suppliers and from the service providers themselves that enable them to act together within this network in a trustworthy format. So the case that we are going to be presenting to you today is this picture taken to the lab setting. So since earlier this year, there was this regulation passed in Portugal, which stated that every single private lab should report back the exams that they are provided in a structured way back to the NHS. And if they don't comply with this, they will not get reimbursed. And so this was the big carrot, or rather stick, that we used to get this started. So right now, we are managing the communication between almost 900 labs and all of our primary care units through this platform. And everything that we do is based around this simple concepts that I just explained to you. So they need to use our semantic assets and our finer specifications in order to share their information with us. And if at any point they require additional concepts, this is all taken care of so that they never get treated unfairly when it gets to the reimbursement side. So this is our numbers right now, and since earlier this year, we have exchanged almost 60 million clinical pathology reports, rare results, not reports. And you see the 75 million account for other areas that are outside of the scope for clinical pathology. And so now starting to move towards the semantic ends of this, the way that we are set up in Portugal is that SPMS is handling what I've just showed you, but when it comes to producing the semantic structures, we are working alongside our National Directorate for Healthcare and ACSS, which is our financial ruler of the NHS. And so we have this cooperation protocol established between our organizations. And it's from here that we can derive our regulation competencies. So we have a couple of working groups set in place right now, but for all of this that Sarah is going to be talking to you about, we have this collaboration going on with our national laboratory, which is Instituto Ricardo Jorge. And so they are the ones that are really curating all of the data sets, all of the information that we are preparing at our NRC. And now I will hand over to Sarah to talk to you about the semantics. Yeah.
Hi, as Filipe was saying, all the healthcare providers needed to report back to SPMS all the results that were related to orders that were requested from our primary care units. And for the majority of the clinical fields, sending back the PDF was enough. But since we had a catalog, since we had a catalog to structure information regarding clinical pathology, it was also mandatory for the laboratories to send back to us the information regarding this medical field. In Portugal, a catalog is basically like a grouper. We group value sets that are related to a specific field. So we have, for example, a catalog for vaccination, for allergies, and for the laboratory analysis. And to support and to give a better context about what the catalog is about, how is it going to be used, we also produce a Word document to describe what is the purpose of the catalog. When the project started, we had already a version of the Portuguese catalog for laboratory analysis, and we had the release 4.1. This release was composed by 2 value sets, coded in LOINC, and 4 coded in SNOMED CT. The most relevant value set for for this use case was the clinical pathology one, because, well, basically when we started, we had like this section, this first blue section that is maintained and it is was created by ACSS. They are the ones that define the rules for the billing for all the prices that are related to each analysis. So these first three columns are are maintained by them. The first column is the column that have the codes for the hospitals. So all the codes that are in this first column can be used for orders in hospitals. The second column is the codes that have the codes for the primary care units. And then in the third one, we have a common description about the analysis that can be ordered. This thread section, we have the requests, so the orders are mapped to. First, we mapped it to LOINC codes, but then we had to change it because LOINC usually identifies the specimen in the LOINC code, and the way we are modeling the information, we separate these two like things. We have the procedures, and then we have the physician also needs to identify the specimen. And then we also identified in the orange section all the results, all the LOINC codes that are expected. They are not always mandatory, but which information the laboratories could use when a physician requests a specific billing code. Then we have a structure for the microorganisms, which it follows basically our structure for SNOMED CT value sets. So we have a first column for the code, then we have some descriptions in English, and then the Portuguese translations. The green sections are used for to understand what type of changes we've made over the time. So the project started in January 2022. The version that was publicly available was the version 4.1, but the first version was released in 2015. Since at that time we didn't have any legislation to support the implementation of this project, basically no one was using our catalog, no one was implementing it. So when it was mandatory, we started to receive a lot of requests to update the information. And since the beginning of the project, we released 7 new versions. Here I present you basically the evolution of the number of concepts in this main value set, the clinical pathology one. The version 4.1, it had 2,077 observation codes. And in the next version, we basically doubled the number of the concepts that we had in the catalog. For now, we have reached a more stable moment. I'll show you the evolution of the number of concepts that we had in our over the time. But as we were adding concepts, we also felt the need to standardize the information more. So for the quantitative observations, we tried as much as possible to identify which codes could be used for this specific context. So we add the AB0 phenotype group, I think, the rhesus factor, the rhesus factor, the blood group. And then for urinary sediments, we have casts, cells, crystals. In Portugal, our laboratories, when they identified the observation, below the observation, they identified also the method. So we also have a value set to identify which methods were could be used to report the information. We had also information about appearance of specimen, color of specimen, and then susceptibility. This susceptibility value set, the information that was on this value set already existed, but we created a lot of rules, and it was easier to separate the information in another value set. The antimicrobial value set, we just renamed it, so it was firstly the antibiotic value set, but at first we only had information about antibiotics, but over the time, laboratories were asking us to include information about antifungals and antivirals, so we had to rename it to be more correct. We also create a value set that is the antimicrobial type, and it is coded in SNOMED CT, and all the codes that are in this value set were also mapped to the antimicrobial, because to make it easier for laboratories to implement the bacteria, which kind of antibiotics are in our catalog. So this was why we also create this value set and the mappings between the antimicrobial type and the antimicrobial. We also had a lot of units during the time, so laboratories were always asking us to include more and more units, because not all of them use the same methods to analyze the requests. So we're always adding this information, and it was difficult to every time we had to release a new version of the Portuguese catalog for laboratory analysis. It required a lot of effort from different teams, so we had to identify a new solution. At first, what we did was every time the laboratory asked us to include a unit, we add like a semicolon per observation. We had a semicolon, then the other unit that was also allowed to be reported with. But then we faced a lot of interesting situations where basically the vendors were reporting, for example, for the item, a result with both units. They didn't choose actually the unit that they wanted to report with. So we received a lot of complaints from the physicians because of that. So what we did was we tried to create a relationship between our Portuguese catalog for laboratory analysis and a value set that we already had in another catalog, which was the Portuguese catalog to support clinical registries. We already had a value set coded in UCOM. And what we did was we add a column to identify the property. So we basically identified not possible conditions, but the concept we had in the value set. We added the property to allow each laboratory to choose what units they wanted to report with. So at this time, for the release 6, we have a lot of rules to our document. So it was at first our document was like the Word document was more like a functional document, but then it moved to a more technical one. Because of the rules that we had to identify. So we established two different types of rules. One for the quantitative results, the one that I explained you before, and then for non-quantitative results, we identify the property and which value set was where we were expecting to receive the information. And then we also identified the structure of the value codable concept for any time that the regulators need to report information with a specific value set. Sometimes the property was not enough. And we had to also identify the code. So in this situation, the microorganism identified in a specimen by culture will allow the laboratories to report using two different value sets. When the result came up as positive, they can just identify the microorganism, and when the result is negative, we have another value set to report the qualitative result. Defining the rules were not enough because the document was so big. So we tried to identify some use cases to put it more practical for the implementers. So we tried to identify at first which analyses were the most requested. We also tried to identify analyses that were related to more errors, and then we also tried to identify analysis that covers the most value sets as possible. So we defined test cases for the enrollment, culture analysis, proactive and fecal cold blood tests. There's a mistake in this slide. I just noticed this one, but for the human culture, we identified successful cases. And for the others, when we identified the successful cases, we were expecting that was a structure that the laboratories need to report with. And for the unsuccessful ones, they represented the we identified some errors, so we made on purpose some errors to the implementers to verify if they were compliant with the rules or not. Of course, the work was not done only by ourselves, so I want to thank all the team that was working with us, and also the National Institute, Instituto Nacional Ricardo Jorge, for the clinical outputs.
Thank you, Sarah and Filipe. Excellent presentation. Do we have anyone in the room who would like to pose some questions or a question? If not, I have a couple of questions from people here. If the project that you started today, would you have, if you were doing it today now, would you do it differently? And in what way? In other words, I guess what you learned from your experience.
I guess we did a lot of mistakes. If we were starting today, we'd start with a different fire structure. When we started this, when there is a legal bill passed, you have political pressure. When you have political pressure, you are bound to make mistakes. But I can say that contrary is true. If we were waiting to have things down to perfection, we would never start. So everything that Sarah talked to you about, especially on the rules side, we are trying to implement it now to increase data quality. But we can come up now with these use cases, with these testing scenarios, because we have failed. So it's kind of tricky. It's a tricky question. We made a lot of mistakes, but we wouldn't be here if we hadn't made them.
Okay, thank you. And another one came into saying, why did you choose SNOMED procedure hierarchy instead of LOINC for orders?
First, in our information systems, the physicians have to identify first the procedure and then the sample. So this was the first reason. Then for the LOINC panels, sometimes the laboratories asked us to include more concepts that were not in the original panel. And since we were modifying the international meaning of the panel, it was difficult. We couldn't really add the information. So we had to come up with a new plan to basically have more freedom to identify the codes that we wanted. And then we also had the situation because when the physician orders, for example, the physician chooses blood, not serum or plasma, and mostly the most concepts that are in LOINC specify serum or plasma and not blood. So this was why we chose to change to SNOMED instead of LOINC.
Thank you. Any more questions? Okay, with that, then I'll conclude the session. Thank you, Filipe and Sarah.